My name is Dr. John Best. I'm a sports and exercise physician with the Ortho Sports Group in Sydney. My practice is in Randwick, where I've been for 30 years. My body area interests in terms of musculoskeletal problems are disorders of the shoulder, the hip and the knee, and a lot of that has stemmed from my work with elite football codes. My involvement has been with the Australian Rugby Union, where I was the Wallabies doctor for a decade. I consult now to the National Rugby League, and have had a short stint in elite football with the Premier League in London with the Fulham Football Club. What I'm going to do now is discuss with you an approach to the stiffening, painful shoulder, a common condition we see in our rooms and quite hard to differentiate. A little later on, I'll show some images to differentiate some of the pathologies. As is the case with any musculoskeletal problem, with the stiffening, painful shoulder, we have a number of red flags to consider. I'd like to just quickly run through them to get them out of the way. Night pain, very common with osteoarthritis and adhesive capsulitis or severe impingement. But as you know, night pain may be indicative of more sinister pathologies, tumour, infection and the like. Fever as well, but also patients who present with heaviness in the arm or paresthesia always consider a neurological component. Is it referred from the cervical spine? And for those patients with fever, are there constitutional symptoms? Problems such as weight loss or anorexia. One of the easier approaches to the stiffening, painful shoulder is looking at demographics. We can split our patient cohorts into those aged, say, 40 to 45 with differing pathologies. Patients under the age of 40 or 45 will frequently present with shoulder impingement, AC joint inflammation, irritability of the long head of biceps, or it may be an early presentation of adhesive capsulitis. With patients in the older age group, adhesive capsulitis is more common, as well as full thickness tears of the rotator cuff and glenohumeral osteoarthritis. We need to remember also, looking at the patient's history, that osteoarthritis is frequently secondary to repeat instability of the glenohumeral joint, repeat dislocations. Now, when we go through our history, a little bit more on trauma, and particularly if there's any overuse component, is worthwhile. The medical history also is helpful. Many patients with adhesive capsulitis have comorbidities. We frequently see this, as many of you would know, with diabetes, thyroid dysfunction, post-surgery, Parkinson's disease, and inflammatory disorders such as arthropathies and seronegative arthropathies. Another feature as well is response to treatment. What has worked and what hasn't. Many patients with adhesive capsulitis will have a poor response to physical therapy, where physiotherapy has made them worse, and indeed many of those will have issues with a non-response to subacromial cortisone injections. So what are some ways we can pick this up and pick up the changes? From a physical examination perspective, we're looking at range of motion and we're looking at power as two key features. So the patient who presents to you with limiting motion themselves, what we call reduced active motion, will have either osteoarthritis, adhesive capsulitis, or severe shoulder impingement. Those patients as well who have reduced passive motion, that is your ability to move them, that's far more common with adhesive capsulitis and osteoarthritis, not so much with rotator cuff tears. So that's important, active motion and passive motion. There's also the end range of motion. Physiotherapists refer to what we call an end feel. As you take a joint to its limit, does it feel stiff or is it supple and pliable? With osteoarthritis, it's a very hard end feel, like patients are hitting a brick wall. You can't move them further. And there may be some crepitus with that. With patients that have a softer end feel, that is, their arm will act like it's bouncing almost at the end range of motion. We see that with impingement and in the recovery phase of adhesive capsulitis. In the back of our mind though, imaging is helpful, and don't forget pathologies such as calcific tendonitis. One of the take-homes I'd like to put forward to you is X-raying your patients. I see a lot of patients who are referred to me with ultrasounds of the shoulder, and often there's a comment about partial tears of the rotator cuff. There may be a comment about bursitis. They may have had an injection for that. But plain X-rays of the shoulder, particularly in someone who is stiffening, is very helpful. You'll see on this first X-ray here what we call calcific tendinitis, a calcific deposit. On that X-ray, that fragment of bone is embedded within the rotator cuff and has occurred secondary to an impingement lesion. This can occur across all age groups, but tends to be a little bit more common in those under 45. The following X-ray here is a plain X-ray of the shoulder of a patient who was sent to me with a stiffening, painful shoulder, and it actually had 3 injections into the ultrasound finding of a bursa. This patient, though, had a history of dislocations when they were younger, and although there are not the typical features of dislocation findings, you'll notice changes in the glenohumeral joint. You'll notice cyst formation at the humeral head and the glenoid. So although this patient is still in their 40s, they actually have osteoarthritis of their shoulder. And many of those patients don't do well with physical therapy and needed to be treated very carefully. The final thing I'd like to put forward to you is the use of local anesthetic injections to help clarify the diagnosis. Our subject here has landmarks outlining the acromioclavicular joint, the acromion, the glenohumeral joint, and you can also palpate the long head of biceps. I like to use local anesthetic injections in the office if there's more than one diagnosis or if the diagnosis is unclear, and it's particularly helpful for the acromioclavicular joint, where you can eliminate pain immediately, impingement, where you can block pain from the bursa immediately, but I tend not to use it diagnostically going deep into the glenohumeral joint. So in summary, when you look at the approach of the stiffening, painful shoulder, don't forget your red flags: night pain, fever, weight reduction, or neurological features. For patients under 40 to 45, shoulder impingement and AC joint are very common. For patients in the older category, adhesive capsulitis, glenohumeral arthritis, and full thickness tears of the rotator cuff, as evidenced by weakness, is very common. And please, don't hesitate to X-ray your shoulders, particularly with impingement, as you may exclude the diagnoses of calcific tendinitis and may pick up some osteoarthritis. Thank you.